Dr. Ajay Aurora has designed an excellent course, and I think his handout was so good that I actually felt that we might as well not do the course. But we have him here. Uh, he works in Delhi, and he's one of the foremost retina surgeons in the city, and it's
Can I have my
basically his
slides?
baby. And over to him.
Thank you, Dr. Dinesh, for the kind words. So welcome to the masterclass on diabetic retinopathy. I have some great leaders in diabetes who are part of the course. They really do not need any introduction. Dr. Lalit Verma, all of you know, he is a great teacher, a great friend, and gives a lot of practical tips. My dear friend, Dr. Dinesh, he is a very sought after speaker, always giving you the rationale behind everything. Dr. Rajiv, I have been reading all his papers since past many months. He has done amazing amount of work on epidemiology and some of the basic work on diabetes. He is a Shankar Netralay. Dr. Vishal, he is a great friend who is based in Jaipur, a very prominent vitreoretina surgeon, has won numerous awards at ASRS. Dr. Ritu, who is happens to be my spouse also. She's a wonderful cataract surgeon, and I have stopped doing my cataract surgery. She does all the combined cases where we do it together. Dr. Bhuvan, a very great friend who is practicing in Delhi from AIMS, and a very prominent vitreoretina surgeon of North India. So welcome to the course. Now, this is what we'll be doing. We have about 90 minutes. After each talk, we will have about 4 minutes of discussion. At the end also, we'll be left with about 10 minutes if we space our talks well. So let me go through the epidemiology of diabetes. The definition of diabetes, all of you know, is a chronic metabolic disorder which is characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. Now, this is a standard definition, and if we look at 10 countries all over the world, the top 3 countries which have almost half of all the diabetic share in the world are China, India, and USA. And gradually, India is becoming the diabetic capital of the world. If we look at over the years, in 2021, 1 in 10 persons were diabetic. There are about 537 million diabetics in the world. In 2030, it will be 1 in 9, and by 2045, it will become 1 in 8. But just imagine, this is the diabetic whom we know. 1 in 2 people do not know that they are diabetics. So they are pre-diabetics. So that is the volume of problems that we have. Now, prevalence of diabetes worldwide, if you look at it, the global prevalence has risen from 4.7% in 1980 to about 8.5%, almost doubled in 2014. If we, of all this, 90% people are type 2 diabetic. In 212, the diabetic retinopathy in diabetics was 34.6%. Fortunately, in 2020, this has declined, the percentage-wise, to 22.7%, but overall the number of figures of diabetics has increased, which I'll share in my next slide. Now, if you look at the distribution of diabetic retinopathy, in 2020, this about 103 million had diabetic retinopathy. Of them, the sight-threatening diabetic retinopathy was almost 30%, and CSME was almost about 20%. This figure is a projected figure to 2045. Now, the estimates of diabetes in India, in 2000, we had about 80 million diabetics. In 2019, we had 77 million diabetes in India. The projected figure for diabetics in India in 2020 was 80 million. We achieved that target 10 years in advance. So that is the amount of the numbers that has grown. This year, the number of diabetics is 101 million, and about 136 million are pre-diabetic. Please remember, of these 136 million, about 45% are going to convert to diabetes. So I should not say that, but it's good to be a vitreoretina expert in these days because the amount of diabetes which is happening is phenomenal and there's a lot of work for us. But and in 2045, this figure of 130 million possibly is going to be achieved much earlier, maybe by 2030. Now, there is a very nice study which was published by ICMR. This is the 2023 data, which shows the prevalence of diabetic retinopathy and diabetes in India. And this figure I've already showed you that how much is in 2023 101 million diabetics and pre-diabetics 136 million. Now, why are Indians affected most? This is because of a typical phenotype which is postulated called the South Asian or an Asian Indian phenotype, which is possible because despite not being obese, we are predisposed to more diabetes. This is because of a higher level of total visceral fat, higher waist circumference, hyperinsulinemia, insulin resistance, and greater predisposition to diabetes compared to the Caucasian population. The main driver has been that there is more urbanization, there is a change of diet even at the rural level, there is a reduced physical activity and increased change of diet. But the most disturbing factor which is that younger people are getting affected. The study which I just quoted had done studies for population above 20 years of age, and that is definitely very disturbing. If you get diabetes below 40 years of age, the chances of your developing diabetic retinopathy are much higher. I will not go into the details, but there's a beautiful article which Dr. Rajiv has published on the role of systemic factors on diabetic retinopathy. You should go through it. Age of onset, obesity, albuminuria, serum lipids, abnormal sleep patterns, hemoglobin A1C, the role of dietary fibers, anemia, the cardiovascular score and neuropathy, and they are all very relevant factors. The worst part is that despite diabetes being so common, the awareness to diabetic retinopathy amongst the caregivers is very, very poor. Also, it is very poor in diabetics anyway, and that is something which we have to address. The paramedics in South Indian population, almost 50% of the respondents were not even aware of the risk factors of diabetic retinopathy. So it is very important that we need to screen more people, and we need to increase the awareness about diabetes, and All India Ophthalmic Society can certainly play a major role. There was a beautiful article which came up in BMJ which told us about the cost of diabetic retinopathy, and if you look at these figures, they are mind-boggling as to amount of money that gets wasted because of inadequate treatment, suboptimal treatment, and not detecting these patients well in time. Therefore, there's loss of working man hours with these patients. So the solution is we have to find out simpler methods of screening, and one of the methods which the Smart India study has proposed, and we are probably looking forward to carrying it forwards, is detecting sight-threatening diabetic retinopathy. If we have biomarkers which can tell us instead of screening 101 million people, we can screen only 30 million people, it will save us a lot of resources. Now, let me just, this is basically an introductory talk, so all of you should know about clinically significant diabetic macular edema, and you should know about that drcr.net and European expert panel divided simply diabetic macular edema into center involving and a non-center involving. If you have a non-center involving diabetic macular edema, a focal edema, it can be lasered, while a center involving diabetic retinopathy needs to be intervened by intravitreal injections. This is a busy chart, but it's important to understand the pathophysiology and what all pathways are involved, because then these can be intervened. I'll share this slide. This was actually shared by Dr. Mangat Dogra from PGI. There was a patient who had refused to get intravitreal injections. This is a story which is almost over 15 years back, and he said he'll do diet control and yoga, and This is what happened after about 6 to 8 months. He responded well. So metabolic control is important at every stage of diabetes, whether it is the early stages or late stages, they must be done. This was one of our patients in the multi-specialty hospital who had come to us, had never shown a nephrologist, underwent dialysis once we saw the retina, and after 8 months the retina had flattened. So it's very important to control these people metabolically. Anemia exaggerates diabetic retinopathy. This was a patient who was thalassemic, and this was a patient I had operated almost about 14 years back. She did not have a hemoglobin going beyond 9 grams. We had given her multiple intravitreal injections, and then we went ahead and did a pars plana vitrectomy without a traction, and that improved oxygenation of the macula, and patient did well. Now coming to imaging in diabetic retinopathy, so these are some of the various modalities that we use. We must do a standard photograph because each photograph tells us a lot of story about what has happened with the patient in the past, what the patient is going through, and it is also an educational tool. You can demonstrate to them retinal hemorrhages, various types of retinal hemorrhages, exudates. You can even show the treatment results in case you go to laser them. And then angiography. So this was a 64 years old male diabetic patient who came to us. Looking at this picture, I cannot imagine that this will be a case of proliferative diabetic retinopathy. But this is many years back, before we could get the wide field angiography, we were able to demonstrate the NVE, and hence the treatment parameters changed and we were able to treat them. Angiography helps us to identify the capillary non-perfusion areas. So you have to have a good metabolic control and do scatter laser in these cases. And oral angiography, especially in patients who cannot you cannot give an intravenous dye or for some reason, then oral angiography can be done, and in a SLO-based system, you can actually get very good images. So the take-home message is that the angiography helps us to confirm the extent of macular ischemia, identifies leaking microaneurysms, confirms area of doubtful NVD and NVE, demonstrates area of capillary non-perfusion, and should be done in all diabetics when you see them for the first time, because it helps us quantify the disease when the patient walks into your clinic. OCT has become virtually the histology of, it's a live histology of retina where you can see all the layers. You can actually compare all the OCT pictures and corroborate it with a colored picture and show it to the patient. You can demonstrate a vitreomacular traction, and you can show that that is not possibly responsible for the macular edema, like in this particular case. There are various patterns of OCT described, and these are very well known. I think these are available in the textbooks. The spongy edema, partial thickness cyst, full thickness cystoid spaces, subfoveal serous RD, and each has a relevance from the treatment point of view, because you can actually decide when to give anti-VEGF, when to do pars plana vitrectomy. Autofluorescence, we know that the vessels in the autofluorescence appear black. The disc is again hypoautofluorescent because there is no autofluorescent material there, and the fovea, most of the thing is absorbed by the lutein pigment. So autofluorescence is picking up interesting observations when we look at diabetic retinopathy, because there are new techniques available which look at some of the other autofluorescent material which is other than lutein, which might be important in cases of diabetic retinopathy, and this has become part of a multimodal imaging. So this is a publication of 2021, which is actually looking at detecting fluorescence due to minor fluorophores, which could be like advanced glycation products, and that can help us understand what is happening at the retinal level. Coming to the last part of our wide field imaging, it was shown that the peripheral lesions are normally missed when you do a normal angiography. So this was a patient who came to us with a recurrent hemorrhage, underwent vitrectomy, and when we did wide field angiography, we were able to demonstrate NVE despite the fact that I thought I had done a complete laser, a large area of capillary non-perfusion. If I had not done this and done a normal photograph, I would have missed all the areas. So that is the advantage of a wide field imaging, which is useful in treating especially these cases and completing your laser in patients. This is another similar patient who had a peripheral neovascularization which got lasered well because we were able to do wide field imaging. So in the end, let me conclude that we are in the midst of epidemic of diabetes in our country. We need to wake up, screen our patients well. We need to gear up as a society and collaborate better so that we can deliver. Imaging is useful and multimodal imaging is really contributing for us understanding and treating the patients better. Thank you very much. I think we can go to the next and we can have, if you want to have anything, because this is an introductory thing, but yeah. If anything you want to point out, Rajiv, regarding the epidemiology.
I think you have covered everything, the epidemiology part.
Closer.
I think you have covered everything, and more recently the Smart India study has come out with the national prevalence.
Yeah.
Even the national prevalence of visual impairment, it's about 21%, which is fairly high.
Right.
And again reiterates it's not only diabetic retinopathy but even cataract.
Yeah.
Ungradables, among ungradables there was high rate of visual impairment.